honor of the invitations. I appreciate it. I was asked to speak about critical ethical decisions in pediatrics, and the fundamental question I'd like to talk about this morning is what should we offer? So ethics being that branch of philosophy, and forgive me, I know this is a mixed audience in terms of clinicians and people in bioethics, and so much of what you're going to hear, whoever you are, is going to be stuff you already knew. My plan is, my hope is that there's going to be something new and different for everybody. But you're aware that we're looking, in general, in bioethics to figure out what we should do, and moreover to figure out how we should decide what to do. With that idea in mind, I want to attack a specific problem, which is how should we decide what treatments to make available to critically ill newborns. Put simply, any treatment that we could be considering, any therapeutic option, is going to fall somewhere on this scale. Ethically impermissible, or permissible, or obligatory. And within the range of permissible, there are some things that may be ethically permissible that we may feel, you may feel as an individual clinician or as an individual person that that's inadvisable. It's permissible but not what I'd suggest, or it's advisable, this is what I'd suggest, or I'm really not sure myself. And the way we can do this is really quite simple. My suggestion is don't offer what is impermissible and refuse if asked. Offer what is permissible and do what is obligatory and insist if necessary. And that's pretty much it, but we still have 40 minutes left, so let's, maybe I can expand on this a little bit. I want to talk about three specific clinical cases, three specific examples. One is whether or not to offer resuscitation in the case of extreme prematurity, and most of the talk is going to be on that specific question. Then talk briefly on Ecmo for respiratory failure and intestinal transplant for short bowel syndrome. Talk very briefly on some information on those two. And of course my hope is that looking at these three specific cases, there will be ideas that carry forward to other questions as well, particularly in the newborn period, but beyond. So let's consider extreme prematurity. The question is, at what minimal gestational age should resuscitation be offered? Is it ever ethically permissible to refuse if requested by informed parents? And how should we decide? Well, most neonatologists do recognize a threshold of some sort. This is data now that are a decade old, and it's a small study, but I leave this here to illustrate the point. This is a survey of Connecticut and Rhode Island neonatologists. We use this because, as I think most of you are aware, Connecticut and Rhode Island are the epicenter of neonatal care in North America. And so here we have it. And what we find is if we ask 45 neonatologists, and I can't remember filling this out or what I said, and I'm kind of glad. But if we ask 45 neonatologists, at what gestational age are you going to say, no, we're not going to resuscitate this child? And we see that 4, I'm loose with this point, we see that 4 would never refuse. There is no minimum gestational age. Now, and the rest we look at here, we say, well, some refuse at 23, almost everybody refuses at 22, like 2/3 refuse at 22, and then everybody by 21, except for those 4 who basically say, I would never refuse. So these 4 would actually attempt to resuscitate a zygote, for which you're going to need a really small laryngoscope. It's a fascinating question, but most people see at some point that there's a threshold. Most of these neonatologists. But I think most neonatologists in general see there is some threshold below which, no, we're not going to do that. So then the work becomes trying to determine where that threshold should be and how we're going to justify it. And an appropriate place to start is with the numbers. So these are data from 21 major academic centers, including Yale, and I'm pretty sure including Hopkins as well, the NICHD, the Neonatal Research Network. And we looked for the time period 2003 to 2007, which is the most recent time period I think we can get for this. And we see the survival at 22, 23, 24, and 25 weeks. Now, I memorized 20 years ago or more that for 23, 24, and 25 was 25, 50, and 75% survival. And interestingly enough, those numbers seem to bear out here pretty closely as a simple tool of recognizing 26, 55, and 72. What surprised me a bit when you see these numbers is 6% survival at 22 weeks. And I think some of you know and some of you may not, when we talk about weeks gestation, we're talking about 22 includes everybody who is 22 and 0 days to 22 and 6 days. And 23 is everybody who's 23 and 0 days to 23 and 6 days post-menstrual age. This is what we're talking about. This is based on best obstetrical estimate. So that said, a little surprised by the 6% because everybody knows that it's impossible to resuscitate a 22-weeker. but as we'll see, a lot of things that everybody knows aren't actually true. There is in neonatology, as many of you are aware, not just a concern about survival, but many of these kids, particularly the very tiny ones, are left with significant disability. So the network, looking at a slightly earlier cohort, also gives us information with moderate to severe neurodevelopmental impairment. That's cerebral palsy, mental retardation, visual impairment, or hearing impairment. And we look to see these at 18 to 22 months corrected age. And these are available online, these data, and this is very helpful. And with these numbers, an awful lot of parental counseling happens. We see at 22 weeks, they saw a 5% survival. Again, this is a slightly different cohort because they got the follow-up involved. 80% of those have moderate to severe neurodevelopmental impairment. And as the survival goes up on the left, 26, 56 to 76, we see that the percentage of those that have the impairment go down. So with these numbers, we can begin to address the question. And this is often what's done in neonatology sections by individual neonatologists. What I would suggest is that we need to take it a little bit further before we do that. We need to consider the limitations of these data. And one is the need for longer follow-up. This is a paper that's well known in neonatology by Maureen Hack, which is now several years old, which showed that if we looked at moderate to severe cognitive impairment at 20 months and looked at those same kids at 8 years, fewer than half of those kids who we thought would have that degree of impairment actually did when they reached 8 years of age. So by looking at these kids at 20 months, we significantly overestimated the degree of disability they were likely to have later in childhood. There have been several papers from then to now. Now the most recent, just this year, looked at patients from Canada, Australia, Europe, and Israel. Again, many academic hospitals looked at these small babies. They looked specifically at the mental developmental index, the Bailey, and what they looked at 18 months and compared it to 5 years. And once again, they saw that 18% of those who fell in the severe category at 18 months remained in the severe category by 5 years. And the average increase was 20 points. Now you're comparing MDI to IQ tests. This isn't an exact science by any stretch of the imagination. But it does show that clearly, by using all these numbers at 18 to 22 months, many studies have shown this from all around the world, we overestimate the disability, which is important because it is not unusual for decisions to be made not to provide resuscitation based on concerns about later disability. A second important limitation of the data is the uncertainty of gestational age. It's not unusual, as a neonatologist, to have an OB resident to come over and say, we have a lady who's just about to deliver, and she's 23 weeks and 4 days. And I say, 23 weeks and 4 days based on what? Well, it's based on, she had no prenatal care, she doesn't know when her last period was, it's just based on an ultrasound we did a half hour ago. She's 23 weeks and 4 days. Now, if you look at this, you see that the accuracy, based on the last menstrual period, is plus or minus a couple weeks. First trimester uterine size, 2 weeks. First trimester ultrasound, 5 days. Second trimester ultrasound, 10 to 14 days. And I think that first trimester uterine size is probably a typo on my part. It's a little bit tighter than that. The point being that when we do this, it's commonly plus or minus a couple of weeks, unless we have an in vitro case where we can be quite accurate, or a first trimester ultrasound. So when someone comes and says, this baby's 23 and 4, based on an ultrasound I did today, that's kind of like asking somebody, what time is it? And they say, the time is exactly 12:27. You say, based on what? Well, based on the position of the sun in the sky. You know, sometimes we pretend to have accuracy we don't have. And as a result, here you have, on the left, some doe-eyed house officers from Johns Hopkins Hospital. And on the right, a lot of you may or may not remember Ned Lawson's movie career. But we have the steely-eyed attending. And now the doe-eyed house officers, when they hear 23 weeks and 4 days, they hear 23 weeks and 4 days. The steely-eyed attending, however, hears somewhere between 21 and 25 weeks, which means the chances of survival are somewhere between 0 and 75 or 80%. It's a very different decision than going to be based on that same information. We have to recognize there's brackets around that uncertainty of gestational age. But before we go blaming the obstetricians, we as neonatologists are guilty, to be sure, of the same thing. We will look at a kid, you'll see a neonatologist look at a kid in the delivery room, and if someone here has done it, I'm sure I've done it too. You'll look at a kid who's supposed to be 24 weeks and say, no, he looks more like 23 weeks. He's 24 weeks by best obstetrical estimate, but I can tell by looking at him, no, he's really 23 weeks. And that's equivalent to a pediatrician seeing a kid in the clinic and saying, well, it says here in the paper he's 24 months old, but he looks more like 23 months old to me, so we're going to call him 23 months old. You can't tell. The best lesson I got on this was, as a fellow years ago, 2 kids were actually born on the same day. They were both supposed to be 24 weeks. And one of them was obviously a 23-weeker. He had the transparent skin, the gelatinous skin, and the ears were so soft. He clearly was a 23-weeker. The other one had much more mature skin. You could tell by looking at him, by the things we assessed, he was really a 25-weeker. Well, I can't really tell you what they were, except to tell you that they were in fact twins. And whatever they were, it was probably the same thing. We can't tell plus or minus 2 weeks. And yet, again, we want to make major decisions about that. So uncertainty of gestational age is an important limitation. Another important limitation, which we've come to appreciate in recent years, thanks to the work of the folks at the network, specifically John Tyson, among many others, is that gestational age alone doesn't tell the whole story. Within a gestational age category, there can be wide variability. Now, let me read this because I apologize. I know that in the back it's hard to see the bottom part of the slide. There is online a specific huge database and a computer program that works with it, so we can type in a few pieces of information and it gives us the likelihood of survival and the likelihood of survival with significant disability. So let's just look at survival to make this point for a minute. So if we give the gender, whether it's a singleton or multiple, whether or not it received antenatal steroids, and the birth weight, we get a predicted survival. So we see a male, twin, born 500 grams, so it might be an estimated fetal weight if he's not been born yet, who did not receive antenatal steroids, has a predicted survival of 9%. Now the network also tells us the predicted survival if the child is placed on mechanical ventilation, and it's actually 14%. They give you survival for different gestational ages overall, as well as survival of those placed on mechanical ventilation. And what we see for 24 and 25 weeks, those numbers are almost identical. But at 23 and 22 weeks, a lot of kids don't get put on mechanical ventilation, either because they failed the initial resuscitation, but for the most part, I suspect it's because people made a conscious decision not to put these kids on a ventilator, not to resuscitate these kids. But that said, we see that this relatively small boy twin with no steroids has a chance of survival of 9%. In the next room, there is a girl who's a singleton and bigger, did get steroids. She has a predicted survival of 40%, a colossal difference. Within 23 weeks, when we quote a number of chance of survival within 23 weeks, it is with a degree of imprecision that we're no longer tied to, thanks to the work of these good people and many others. But maybe gestational age alone, when we're trying to draw that threshold, where do we refuse, is the wrong criterion. Look at this again. If we take that same case, but make the boy 24 weeks and the girl 23 weeks, and we see here that it's still a boy of 24 weeks, a small boy at 24 weeks, has a poorer prognosis than a larger girl at 23 weeks. Now the same would be true, in fact, if I made the boy 23 and the girl 22. So consider that this girl has a much better prognosis, as far as we can tell, if there are no other complicating factors. Does it then seem fair to say to the parents of the boy, you get a resuscitation if that's what you want, but to say to the parents of the girl, who has a better prognosis, you don't, because your child is 23 weeks, not 24 weeks, or wherever we may have chosen to draw that line? I think it becomes a fundamental issue of fairness or justice. If we use gestational age alone, I think we have the potential for unfairness, as these data illustrate. So the third thing I want to talk about is the self-fulfilling prophecy as a limitation of the data. And this is something I was actually able to get out thanks to Ned, who was kind enough to publish it a few years ago, how important this is with relation to preterm babies. So I was trying to understand what to do at 22 weeks and talk to various people at various centers. Should we try to resuscitate babies at 22 weeks, really? Because some people have survivors. Should we be doing this? So I was talking to a colleague at another medical center, bright guy, went to college and everything, I'm pretty sure. And I asked him, I said, what are you guys doing at 22 weeks? And he said, we never resuscitate at 22 weeks. I said, good. He was quite sure. Good, I'm glad to hear it. I said, so why don't you resuscitate at 22 weeks? And he said, because we've never had a survivor. Congratulations. That works at 25 weeks too, by the way. So this, unfortunately, is the thinking that's going into, and by the way, not just extremely low birth weight babies, but other problems as well. Some people can make the same argument about things like trisomy 13 or 18, where we say the vast majority of them die in the first week of life because we don't try to save them. What if we tried to save them? This self-fulfilling prophecy with regard to extreme prematurity is hugely important when we look at the numbers. Here are the most recent data that came out about survival at 22 weeks. Keep in mind that survival at 22 weeks was 6%. 6%, for those of you who took arithmetic in grade school, means 6 out of 100. But resuscitation was only attempted in 19%. So if I'm trying to figure out what are the chances of saving a kid at 22 weeks, Do I say, well, the chances are 6%? And again, the disability argument is separate for the moment. We're talking about survival. So I recognize the disability argument is important for many folks. But we misinterpret the data here. Is it really 6 out of 100? It seems to me that it's 6 out of 19. We tried it 19 times and we succeeded in 6, which gets to the relevant question regarding an individual patient. When we're trying to decide whether to offer any treatment to a patient, we don't say what are the survival and disability for all children born at this gestational age or for all patients with this disease. That doesn't tell us whether or not a specific treatment is likely to be effective. The question, the relevant question, is what would be the chances of survival and disability for this child if we actively resuscitated and provided aggressive NICU care? That's the relevant question, which is why 6% may be a very misleading number. What I would also suggest to you is that parents have a right to be told the answer to the relevant question, even if they're not savvy enough to ask it. We need to ask it and do our best to answer it, even if the answer for a given disease is, I don't really know. Let's try and get a handle on it for this. If we look again at the NICHD database, a slightly different era, the survival at these ages of those, if we exclude those where they didn't try to survive and exclude those who were less than 401 grams, this gives us an approximation of what if we tried. If we tried and received 22 weeks, there's a 20% survival, which is surprising because everybody knows it's not possible to survive at 22 weeks. 23 weeks, that 25% number went to 36. And at 24 and 25 weeks, you see the numbers are the same because they tried to resuscitate in almost every case. 20% of the 22-weekers is a surprising number. In most cases, as you can see, I put it on the slide so I have it here in case we needed it. Most of the 22-weekers, no one tried to resuscitate. And this point here is not to tell you that we should be resuscitating at 22 weeks. The point here is to tell you that if the argument is we're not going to try to resuscitate at 20 weeks because it can't possibly succeed, I would suggest to you that we're kidding ourselves. If we look at the data from Japan, just briefly, 22-week survival of those admitted to the unit, 34%. So it's not a fluke, it's not a couple people who did a bad job assessing gestational age. 23 weeks, 54%. At University of Illinois, Southern Illinois down in Springfield, for just after the surfactant era, so for nearly 20 years, they resuscitated every 23-week or did the best they could from an obstetrical and neonatal point of view, and the survival was 40%, not the 25% that we reported. Again, similar to the numbers we see from the network of those who were placed on a ventilator. So it's an important limitation of the data, the fact that we need to factor in the self-fulfilling prophecy. But back to the question at hand. When is it ethically permissible for us to refuse the parental request? And is it ever permissible? It comes down, I think, to the physician's role. So on the left here, let me use this pointer since there are pen nothing gives me. There we go. On the left here, Ruth got to mention a couple of those schools I managed to sneak my way into. So on the left is home base. That's Yale School of Medicine. When I first developed an interest in bioethics, I started by auditing courses. And I audited a course over at the law school, which was about half law students and half public health students and one middle-aged neonatologist. And we sat around, and they presented a difficult case. And in the end, the question was, who should decide how we handle this case? It was a medical ethics forum. Who should decide? And the room's quiet for a minute. And then this young woman, I can't remember her name, I suspect I probably worked for her now, I don't even realize it. She said, well, it certainly shouldn't be the technician. And I thought, the technician? Oh, she means me. It certainly shouldn't be the technician. I'll not forget that moment. These were obviously young, intelligent, the leaders of tomorrow, which, by the way, yesterday's tomorrow is now, my fellow technicians. So then I went off to grad school to study this stuff more earnestly and for real. And I went to Brown, and I was standing around the philosophy building the day before classes started. I was still working at 2 hospitals. And I went there, and someone noticed that I didn't look like the regular graduate student, being 20-plus years older. And she was a member of the faculty and said to me, what are you doing here? So I explained, well, I run an ethics committee at the hospital, actually 2 hospitals, and I want to try and understand these things better, so I'm going to school to study philosophy. She looked at me and says, that's just ridiculous. Okay, she said, doctors should just do what they're told. Okay, so there's medical, oh, and the doctors are aghast, and some other people are saying, they're absolutely right, damn right. Doctors should just do as they're told. So I'm wasting all my time on this ethics committee. We should just do as we're told. And it occurs to me that I need someone to blame for this unfortunate trend. So I choose to blame the Australians. This is one of my favorite restaurants here. This is authentic Australian cuisine. I don't know if you guys have this kind of fancy stuff in Baltimore, but up in Connecticut we've got this Outback Steakhouse. And if you go to the Outback Steakhouse and you sit there and a nice person comes over and they get right next to they're in the booth and they say to you, what would you like? And if you say, I would like a ribeye steak medium rare. They don't say, no, you want that well done. We're going to make that well done for you. I don't want to hear that. I'm paying for the steak. Tell the guy who makes the steak that I want the steak medium rare. And I certainly don't want to hear, you know, Pop, maybe you should just have a salad. I don't want to hear that. I'm paying for this, so give me what I'm telling you to give me. The problem, my friends, is that many people, from graduate students at Yale to professors of philosophy at Brown and others, think that you and I are the guy who makes the steak. If we don't think we're the guy who makes the steak, then we have to decide, when are we going to say no? When we're told to do something, or asked to do something. We need to find some method to determine where that limit is. The method we most commonly yield to in clinical medicine is the standard of care. The standard of care. And this on the right is the Yale seal, Lux et Veritas, which, for those of you who speak Latin know, that means because we say so, which symbolizes the standard of care. That is the foundation of the standard of care in so many things. Well, let's talk about the standard of care and other things in medicine first, because I think there is not a perfect analogy, but a reasonable analogy to be made for a scientific question. What do we do for this disease? The resident asks the attending, and the attending says, for this disease, we treat with ampicillin. Why do we treat with ampicillin? We treat with ampicillin because in multiple trials, this is shown to be more effective than other antibiotics or placebo. And so, therefore, we treat with ampicillin. Okay, that's the standard of care, based on some sound scientific evidence. Excellent. Or, we treat with ampicillin because there are no good studies. But from what we know about ampicillin, and what we know about this disease, it seems like this disease should respond. And that's been generally my clinical experience. So that's our standard of care. Okay, not as strong. How about this one? This is just what we do. We treat viruses. We give them amoxicillin for viruses because it's just what we do. It's the standard of care. Leave me alone. Okay? I would suggest to you that the obligation of that resident to adhere to that standard of care, or of any of us to adhere to standard of care, is proportional to the scientific rationale behind that standard of care. In like fashion, I think our obligation to adhere to an ethical standard of care is only as strong as the ethical arguments behind that standard of care. So, for example, we don't resuscitate at X gestational age. Why not? Because we all got together and we decided, we're not doing this, right? Right, okay, right. Because we say so. Or, we considered in great detail the pros and the cons, the ethical arguments for and against, and this is what we came up with. So this is our standard. I think there's a difference between the two. Again, not a perfect analogy, but an analogy for physicians worth thinking about. Because so many of our standards in medical ethics are just, we took a poll and 8 out of 10 decided that we're not going to let the Italians vote, so the Italians don't get the vote. We got to do better than, it's okay, I'm Italian, take it easy. We need something better than because we took a poll and that's what we decided. I want to suggest to you, and it's certainly, you could have your list. For me, there's 3 valid reasons to refusing to resuscitate that baby. One is futility, the other is fairness to others, and the third is patient's best interest. And I would work through that briefly if I could. The first is the issue of futility. The word is from the word futilis, the Latin, which means leaky. Because on the right, you see the daughters of the god Danaus who were condemned forever to carry water in leaky vessels. It doesn't work. So futile means it can't accomplish the desired goal. I've written and spoken and read to many people about this. There's clearly a broad consensus within our profession that we're not obligated to provide futile treatment that can't accomplish the desired goal. In the surgical literature, in the medical literature, the pediatric literature, etc. Interestingly, when one speaks with people outside the medical profession, that consensus is far less certain. There are those who think, yeah, you should try even if it has no chance of success. Which brings me to Dr. Unguru's trip to New Haven. A lot of you haven't seen the beach in New Haven. But this is not New Haven, this is West Haven. But we went for a walk on the beach. And there were two little kids on the beach. And they had dug a hole in the sand, and they were filling up their buckets with water, and they were pouring it in the hole in the sand. They were running back and forth. They saw us walking down the beach. We were talking about, I think, John Stuart Mill or something like that. And they said, oh, maybe you guys can help us. We're having a problem figuring something out. And your aunt said, well, of course, we're bioethicists. And they said, oh, okay, good. My brother says what we're doing here is futile. And I say it's not. Is it or is it not futile? And we were watching what they were doing. They were filling up their buckets with water and going back to a hole in the sand a few feet off the edge, and they were pouring it in the sand. And so they looked at your aunt, because he looks much older than me, so they figured he was wiser. And they said, is it futile or not? And don't tell him what you said. What did he say? He said, what are you trying to accomplish here? And the kid said, well, I'm trying to empty the Long Island Sound into this hole in the sand. And he said, that's futile. And his brother said, what are you talking about? We're just trying to get the sand wet so we can build a sandcastle. And he said, it's not futile. How sad that these kids were working so hard on something, and they hadn't even agreed on what their goal was. For those of you who do clinical ethics consultations, you will see this every time. You will see this every time. People argue, it's futile. Is it futile? What are you trying to accomplish? Well, I want to get this old man back on the tennis court. Okay, it's futile. Well, I just want to keep him alive till his daughter's wedding. Okay, it's not futile. What are you trying to accomplish? I suggest that that goal largely needs to come from the parents or the family rather than us, though it's something we can reach together. But we have to have the conversation in clinical ethics, which is so often lacking. The second potential justification for refusing is fairness to others, which I'm only going to touch on briefly here because I don't think we need too much time for this. The first category, which we talk about a lot in bioethics, is distributive justice. And I put here that I don't think this is an appropriate bedside decision in most situations, which is to say I don't think we should balance the federal budget on this particular baby's back, this baby we're trying to decide whether or not to resuscitate. I do think that if at some point, if we actually have developed the political courage among our leadership to have this conversation, this may be the future. We may say that we have to draw a line both at certain gestational ages and perhaps at certain other ages. Maybe there'll be one line at 24 weeks and another at 84 years. I can't tell you where the lines will be drawn. What I'm saying is that this is something that I don't think should be decided for an individual child or an individual case based on distributive justice. Because the chance for unfairness is obviously great when you're making a decision about that child and he's making a decision about this child, and they're very different. And they could even be in the same unit or in the same city. We need to have this societal conversation. I suspect in this room, pretty much everybody knows that this needs to happen. And amazingly enough, in the outside world, there is not yet agreement on that, at least in the United States. The second argument would be fairness to family members, if we're talking about fairness to others. So distributive justice speaks to fairness to the whole society, the other patients in the society, the kid in society who might not get his free lunch because somebody else took care of a premium, and how do we balance that? Fairness to family members, I don't think is an argument irrelevant to this question. Because if a father and mother come to you and say, I'd like you to resuscitate this baby, and you say, I refuse because it wouldn't be fair to your other children, or I refuse because it wouldn't be fair to you, what would you say? What you would say is, the hell with that, I'll decide what's fair for my other children. You don't make decisions about what's fair to my children. You want to make decisions about what's fair to society, that's one thing. You want to make decisions about what's fair to my other kids or my wife and me? We'll figure that out. I'm asking you to do this. So this, I don't think, is going to be where the money is in terms of refusing. Nor is futility going to be where the money is because the word has been so overused. But there will be some cases. For example, at 21 or 20 weeks, I think that the argument to futility is actually a reasonable one. So there will be times when we can say we're not going to do this because it cannot achieve the desired goal. But most of the time, where the money is going to be in a much more vague and difficult concept called patient's best interest. When we consider the patient's best interest, we say we will weigh the benefits to the burdens, to the patient. If the proposed treatment, in this case resuscitation, if the benefits appear to outweigh the burdens, then it's in the patient's best interest to do it. If the burdens appear to outweigh the benefits, then it's in the patient's best interest not to do it. There are many other things that can fall into this concept. Maybe afterwards, if you want to, for a few minutes we can talk about. But very quickly, the harm principle, which in pediatric ethics at least, means something a bit different than what it means to those who study philosophy. The harm principle that phrase has been used to describe the notion that we don't really require parents to decide what's in the child's best interest. We say that you have to decide for your kids, and your decision has to keep above a certain threshold of harm. So for example, if it's in your child's best interest to take him to Johns Hopkins, it's okay if you just take him to Yale. as long as you're above some threshold of harm. Okay, so we can make these arguments in general so that the parents, though we talk about we have to decide based on the patient's best interest. In fact, parents are not really held to that for most decisions they make for kids. It might be in your kid's best interest to send them to private school, and you've got the money. But no one's going to come to your house with a policeman if you sent the kid to public school instead. But if you sent the kid, you just let him watch TV and eat Cheetos all day, yes, then someone's going to come to your house and knock on the door and say, no, you've now fallen below that threshold of harm. The right to life and right to mercy really refer to, if you will, the two extremes here that we sometimes deal with. And they can be used as an argument. The right to life means, in this case, the right to treatment that's likely has a decent chance of saving the child's life. The right to mercy refers to the child's right not to be subjected to treatment that is painful and unlikely to yield any benefit to the child. These are the things we balance in benefits and burdens. We consider the interests of others sometimes. Now, mainstream ethics says that patient's best interest standard should just be about the patient. But as the philosopher George Carlin once said, the reason the mainstream is called a stream is because it's so shallow. And you know that many discussions have been had by Hardwig and others for a long time that we can consider the interests of the other family members. How much should those weigh against the interests of the child? This is a discussion worth having. Is it different for babies and older children? Should it be different for babies and older children? These are discussions we need to have. These are discussions that clinicians rarely have the patience to have. But all these things go into trying to figure out if something's in a patient's best interest. And in the end, it's still a value judgment. If there's a 5% chance of survival, and of those, half of them are going to have significant disability, is it in this kid's best interest to take that shot? It becomes, to a great extent, a value judgment. So the question becomes, whose values count? Whose values trump? Here you have the typical Yale pediatrician, and here you have sometimes the parents, thoughtful, intelligent, loving parents, and here you have sometimes the parents who are just kind of confused and out of their element and can't really help you very much. Whose values trump? It's a difficult question. What I would suggest to you in the interest of time, I will tell you what the American Academy of Pediatrics has suggested after much deliberation on this, the Committee on Bioethics, which Maggie and I serve on together, but this was the people who served before us. And what they said was, the parents' values trump. We need to give the parents wide latitude in decisions like this. But we should seek to override them when their decision clearly is opposed to the child's best interest. So if we're somewhere in here, we got to just yield to the parents. But there's going to be some threshold where what they're asking us to do is clearly opposed to the child's best interest, where we should, in fact, not do what we're told. Now, the AAP Committee on Fetus and Newborn, again, this is a standard of care, so we need to take it with a grain of salt. I wasn't there when these deliberations happened. They say that if there's no chance of survival, resuscitation is not indicated and should not be initiated. If you consider a good outcome to be very unlikely, then parents should be given the choice. This could be looked at really in terms of that first scale I showed you, impermissible versus permissible, but not necessarily advisable. Which is to say that if there's a good outcome is very unlikely, then one might say that really attempted resuscitation is not advisable, many physicians would say. But that's not the same thing as impermissible, and parents should be given that choice. By the way, they can't really be given that choice unless someone tells them that they have a choice. Now, briefly, I want to touch on two other therapies and how they're, much more briefly, and how they relate. This is Ecmo, extracorporeal membrane oxygenation. It is essentially heart-lung bypass for children, newborns, and others, and it's used on adults as well. But for newborns with respiratory failure that has not responded to ordinary mechanical ventilation. As you can see, it involves lots of machines. It's also very labor-intensive, and it typically lasts for 5 to 15 days. We sent out a survey a couple years back to all the Ecmo centers in the country, actually not just in the US, but in Europe as well. And we asked them some questions about when Ecmo is applied. And just very briefly, let me show you. We asked them a question. If patients meet the respiratory criteria and there are no other contraindications, would you offer Ecmo in the presence of trisomy 21? And they got the answer never, rarely, sometimes, usually, or always. I have to tell you that it was not that long ago that the idea of putting a child with trisomy 21 on Ecmo was like, no, we don't do that. And why don't we do it? Because it's not indicated. Well, okay, why is it not indicated? Well, you know, because he's not a candidate. And we've got all these buzzwords to say we don't do that here, or because we say so. But he's not a candidate is not an ethical argument, any more than it's not indicated is not. It's not an ethical argument. So what did they say? What they said was, never or rarely, we'll take that as a no, or usually or always, we'll take that as a yes. So what happens? 12% said, no, we don't put kids with Down syndrome on the machine. And 68%, that should have been 88%, I apologize. No, 68%, because some of them were in the sometimes range. 68% said, yeah, we do. So 1 out of 8 centers will say no when they have a child who needs ECMO. The question I would have, which wasn't in this questionnaire, and the question I would have if this came up was, well, do the parents know that the place across town does it? When they were told, no, you can't have it. It's a life-saving treatment for your child. You can't have it. Why? Lux et veritas, because we say so. Well, what about, I suspect that the arguments years ago, frankly, I don't think this would be an argument. There are no data that show that ECMO is less successful in kids with trisomy 21. This is about mental retardation and those who think you shouldn't work this hard to help kids who have cognitive deficits. Ironically enough, that no one seems to be questioning GI surgery or even heart surgery for these kids anymore, but yet ECMO in some centers is still considered something that is not even offered to parents. Moderate hypoxic ischemic encephalopathy, never or rarely 40%, usually or always 43%. People were completely divided on this. Should this moderate degree of brain damage from perhaps birth asphyxia mean you're no longer eligible or a candidate for ECMO? Again, there's no evidence that those kids will do worse or less likely to survive the treatment. To people with CNS injury, to people with intellectual disabilities, are they less likely or less deserving of this therapy? Obviously this comes up. Once again, the question must come up, were the parents told this? And many, many conditions like this, DIC, certain weights, etc., where there is no consensus within our country about who should or shouldn't get this. Not only has there been no consensus, but it's important to note there's been no conversation between these centers about what's available. So is ECMO ethically obligatory? We asked the question, how often would you seek to override parental refusal of ECMO for a neonate you feel is likely to survive with a favorable neurodevelopmental outcome if he received the ECMO? Would you override the parents? Now that then becomes, we move from impermissible to permissible, where we offer to them, to where it's obligatory, where we don't offer to them. At 30 weeks, we don't say to the parents, would you like us to resuscitate your child? We say, we're going to resuscitate your child. And the parents say, no, let him die. We don't, because we think that child's chances are so good that he has a right to this treatment. Can ECMO fall into that category? What do you guys think? Well, whatever you think, you're in good company. Never, rarely, sometimes, I know that folks in back can't see it, never, rarely, sometimes, usually, or always. There's absolutely no consensus on whether ECMO should be ethically obligatory. And there is no conversation within the ECMO community. And it seems like Ned and I are getting to be pretty good friends here because, believe me, you want to talk about finding people who are interested in these data, the people who do ECMO are angry about this. Not Ned, though. He says, yeah, well, hell yeah, we'll publish it. So it's... Last, just very quickly, intestinal transplant for short gut syndrome. For those of you who aren't clinically oriented, some babies are going to lose the majority of their intestines. For a couple different reasons they might lose it. And then the question becomes, do we try to keep them alive on total parenteral nutrition until they can be a candidate for this surgery? I was asked, when I was visiting a professor recently at another university, are the parents obligated to keep them alive on TPN until they can have this surgery? And I thought, holy crap, we're still at the place where should we offer it? And some people at the place where we're trying to figure out if it's in the permissible zone. Some people are already trying to figure out, is it in the obligatory zone? We did a survey of neonatologists and surgeons, and we asked them if they thought it was ethically permissible. And we see that almost nobody thinks that it was impermissible, and almost nobody thinks that it's obligatory. The dark blue is neonatologists, the light blue is surgeons. The point is that 90% think that this is permissible, but only 1 in 3, if later in the same survey, if they're asked, do you offer this, only 1 in 3 offer it, even though almost everybody thinks it's permissible. This is a real problem, and this I've encountered not just with this, but with all kinds of different questions. We're not going to offer it, but if the parents ask for it, yeah, we'll do it. If you would do it if the parents ask for it, and if they don't happen to have a sister who's a doctor, or happen to be really good at the internet, they don't even know enough to ask for it. That's not fair, that's not right. The people who know more about the business have a better chance at these procedures. I'm not saying it should or shouldn't be done. What I'm saying is that people have a right to know. So let's wrap it up. By 1 o'clock, as promised. The critical ethical decisions need to be based on 3 things. The first is honesty. And Shakespeare is here because I went to high school. And when in high school I learned one play, it was Hamlet, and the father saying to son as he sends him out into the world, this above all to thine own self be true, that it must follow as the night to day, thou cannot be false to any other man, or something like that. And when he said to thine own self be true, I don't think he was saying, you know, like the Beach Boys, be true to your school. I think he meant be honest with yourself. But just to be sure, I actually called a professor of English at Yale years ago, and I said, so what did he mean? Be faithful to your ideas or be honest with yourself? And the professor of English said, some people think he meant, thanks a lot. And they get like 3 months off in the summer. So I would suggest to you that with regard to the data, we have to be honest with the parents. But first, we have to be honest with ourselves, that there are some things we don't know. What if we really tried with this disease? Well, we don't usually try, so we don't know what would happen. It's okay to say we don't know. We have to be honest, first with ourselves, then with the family. Now, justice and fairness means that if we're going to treat people differently, there needs to be a morally relevant difference. We need to figure out why we're going to offer resuscitation to one newborn and not offer it to another. And I would suggest to you that gestational age is not that morally relevant difference. Prognosis will be, but prognosis is based, as we saw, in many factors, gestational age being only one. So to draw a hard line at gestational age, now that we have these other data that are better at giving us prognosis, I think is a mistake. The last would be transparency. Parents have a right to know what we're doing here. And if transfer to someplace else is feasible, and we don't do it here, but they do it there, they have a right to know that too, and they shouldn't have to be savvy enough to ask. So when we're trying to figure out what given treatment, where it falls on this scale, impermissible, permissible, or obligatory, this determination is going to require an understanding of the data. And as we learn more about the data, things are going to move one way or the other. The new study comes out that shows this is 98% effective, well, maybe it's obligatory. A new study comes out that shows this has no benefit at all, maybe it just moved from permissible to impermissible. Things are going to move based on the data, but also based on our mores and our ethical analysis of the situation, which needs to be ongoing. I think, for example, the idea of Ecmo in the setting of Down syndrome moved, not Ecmo, heart surgery or GI surgery, but certainly Ecmo for Down syndrome went from impermissible to permissible without a real long discussion or ethical analysis. I don't disagree with it, but these things kind of drift around. We have to talk about it. I know I'm preaching to the choir. This is those who will take the time to discuss it. Not everybody will. The final thing I think it's going to require, as we figure out what to offer in the newborn period, is a recognition of moral agency. That is to say, we, those of you who take care, doctors, nurses, and others who take care of sick children, are moral agents. And only in the world of my PowerPoint creativity can Yale Children's Hospital be bigger than Hopkins, but there you have it. We're responsible for what goes on inside the walls of these places. We are moral agents responsible for our actions. We are not, I would suggest to you, the guy who cooks the steak. We don't have to do everything we are told. But we do need an ethically defensible reason for refusing it. It has to be something more than because we say so. I thank you so much for the invitation.
Talk. All right, so we have basically 15 minutes, and are you comfortable just calling one?
Yeah, sure.
So.
Please.
I had Ray Duff at Yale for my public health seminar many years ago, and I'm interested in how genetics today fits into these team decisions.
How, say again?
I'm sorry?
You're interested in?
In how genetics and other team members fit into these sort of decisions in the NICU and the Haven today.
Well, that's an excellent question. So when we try and decide about this particular question, about extreme prematurity, or any of these, Ecmo or small bowel, genetics doesn't really play a part in this, or short bowel rather. Genetics doesn't play a part. However, when we discuss what should we do with trisomy 13 and 18, where the geneticists have a great deal of experience with these kids, certainly more than us, later on in life, those who survive, then they do play an important part. So genetics will be involved when we're talking about what to do, whether or not to do heart surgery on a child with trisomy 13, CT surgery will be at the table. When we're talking about resuscitating extreme premature, then it's primarily the neonatologist. So it depends on those who have the expertise. Renee.
I guess I'm wondering if, there was a paper I'm blanking on, I think it was in Peds Critical Care a couple of months ago, although maybe it was in Pediatrics, where they presented 4 hypothetical scenarios to a bunch of PICU docs and asked them when would they override the parents' wishes. And one of the scenarios that really stuck with me was for an HIE baby, a baby who sustained significant brain damage and was ultimately declared brain dead. And a third of the PICU docs would not root I think that's the fear that comes with the giving families too much of a role in some of these decisions that are that really should be not allowed decisions. The decisions to keep alive on life support a child who is already dead should not be a decision that anyone gives to the family. But clearly, if the decision is given, a third of doctors will let them have it. So what do you think about that?
Well, I would suggest to you that by giving, in a case like that where a child is actually brain dead and on a ventilator, and by giving the parents the choice, does them no favors. It gives them the false impression that they get to decide when their child is going to die. And it gives them that potentially that guilt for a very, very long time. And I actually encountered a case like this when we were having trouble with the mother of a child with a brain tumor that was growing, exactly what should be done. This was in pediatric ethics consultation, a teenager, and it was a grandmother. And the oncologist and the pediatrician, they say she insists that he be intubated when he stops breathing, and then the anesthesiologist said, so when are we taking the tube out? I mean, what exactly is the end point here? Are we going to resuscitate and so on? And I was asked to get involved. I spoke with her, and she said, well, you know, when people are making decisions you can't understand, well, why do you want to do this? And she said, and I have no way of knowing if it's true, but in her mind it was true. This is how she interpreted it. She said, you know, my sister was brain dead, and they let me decide when to take her off the ventilator, and I never got over it. And I've never forgotten what she said to me, that she feels now, you know, 20 years after her sister's death, she still feels the guilt because she thinks she killed her sister by taking a brain dead woman off a ventilator. I think at some point, I believe also in giving families wide latitude, but at some point we do them no favors. We do them a disservice by pretending there's a decision. I feel the same way about offering people DNR and someone who's clearly going to die in the next 10 minutes. And I think that what some people want to do is lie about it or do a slow code. I think that's an unnecessary deception. Some people say, well, it's up to them. We've got to let them decide. Well, we can't always say, would you like us to resuscitate your child? Yes. Well, too bad we ain't doing it. Once we offer it to them, then a very common question that comes to me is, you know, the parents refuse to make this kid a DNR. And this is crazy. He's going to die like in the next 24 hours. Nothing we can do. We're looking, okay. Well, they refuse to make him a DNR. Well, so someone obviously offered him DNR. So to offer him DNR is to offer him R. Because you offered them a choice. They made a choice. You don't like the choice they made. At some point in some situations, offering people a choice is not a service, but actually a disservice. I say that with caution because obviously the risk is that we go too far with the paternalism and we don't offer people fair choices they deserve. But in the case of a brain-dead child, I would agree that that's going too far. And I would say, for example, listen, I know your family's coming in from out of town and people want to be here while the body is still warm and pink. I said, so we're going to keep him on the ventilator until 7 o'clock tonight, and then we're going to take him off the ventilator. You know, something along those lines, rather than let people, because it happens. Kids in the ICU for days or weeks who are brain dead on a ventilator. I don't think you're obligated to keep dead people on a ventilator. And I think it's not helpful. Maggie?
Yeah, this is really interesting. I've been working with the residents here a little bit lately about the ethics in uncertainty, when you have to make a decision and the data is somewhat uncertain. And one of the things that comes up is that physicians have varying degrees of ability to manage uncertainty as well. So how do you do this then? I mean, I think your point about the data is not entirely clear, and we have to somehow come to terms with it ourselves and also present it to families in a way. When there's such a wide range of capacity to handle uncertainty in docs, and I'm assuming the same wide range in families, how does your group approach it? Like, do you have some magic in sort of getting people to clarify some of the uncertainty?
Well, certainly no magic. I mean, what I would say is that for many questions, and what I try to do, and it's not easy, is get the entire section together and say, here's the question we have to answer. Now, let's not with a kid in front of us while we're sweating blood here trying to figure out what to do. There's no patient with this problem today. Let's work through the problem. Let's work through the ethical arguments for option A, for option B, and option C. Let's consider the counter arguments, which I tell you, clinicians just love that stuff. They want to like shoot themselves when you're going through that stuff. But the fact of the matter is, you know, it may take a couple 90-minute meetings, but if these are important questions, let's as a group reach a decision about how we're going to manage this. And by the way, we have to do it as a group. Because if you and I have different opinions, and I say, well, listen, I said, if your baby's born, I'll resuscitate him. But Maggie's coming on at 5. No way she's doing it. I said, so if he's not born by 5, you're out of luck. Unless you can really hold on, because I'm back at 7 a.m. We have to agree. And some people are not going to get their